Um, this is lovely. It's live streaming, correct?
Yes, you are on.
Okay, fantastic. Good evening, everyone. Welcome to Medical Mondays with Dr. O. Welcome to another educative session, another wonderful evening. I am Dr. Toyin Okwesomi. I'm a family practitioner, HIV specialist, and I treat substance use disorder in Maryland. I also enjoy what we're going to do tonight, just for us to learn from each other and to get stronger with and from what we learn. So before Martin Luther King Day, I said we will be starting a series on financial health. We had a fabulous time with Douglas Eze, and Mr. Daudu chimed in. However, Dr. Famuyiwa had been scheduled to speak way before. So we're going to do that tonight. And next week, by the grace of God, we will start our series, or continue our series rather, on financial health. Stay tuned for amazing time on learning how to create generational wealth. But tonight, we have our very own one and only, the best fertility doctor we have around us, Dr. Oluyemisi Famuyiwa. The floor is yours.
Thank you so much, Dr. Okwesomi. Thank you for that kind introduction and warm introduction. Medical Mondays holds a special place in my heart. I enjoy being here. I enjoy the interaction, and I hope we will have a fun evening tonight. So before I go further, thank you for sharing your dinner hour with us. And let me go on to the next slide, which is not moving. Oh, there we go. All right. So my name's Dr. Famuyiwa, as I've been introduced, and I run Montgomery Fertility Center. And I also am a clinical professor at George Washington University School of Medicine. So tonight I decided to shake things up a little bit so that I could invite questions. And I thought, you know what? Let me tackle some of the myths that are out there, some of the fiction, if you will, the misinformation going on, and see what we could come up with. So I'm going to go through a series of about 14 fact fiction kind of thing with you guys. And then at the end, we will sit down and have a discussion. So the first thing I wanted to go over the fact is, you hear this a lot. It's a woman's problem. It's always the woman's fault. And the truth of the matter is, infertility or lack of fertility is actually 1/3 male related, 1/3 female related, and the other third is a combination. So you see, when you take it all in all, it turns out it's actually a 50-50 proposition. So it's not always a woman's fault, and we should debunk that myth. Now, another thing you might have heard is, oh my gosh, no woman can get pregnant after age 35. Well, the truth of the matter is, maybe 1 in 8 women have infertility, or depend on which statistics you're looking at, 1 in 6, right? So that means that, a lot of women out there are still having babies after the age of 35. So that's not true. Does male fertility have any factor to do with age? Well, while men are gifted supremely with the ability to continue to make more sperm, the fact of the matter is that sperm quality will decline with age. So we have a higher incidence of DNA fragmentation that continues to increase with age. And that can lead to aneuploidy, which I tend to look at as genetic accidents, is what I call them. When the DNA of the man and woman doesn't quite align well, you'll get errors in translation. So men should consider freezing their sperm, and it doesn't matter what age, just do it, because it's an ongoing decline. Now, another thing that you may have heard about is couples should try for a year. before seeking help. I tend to disagree. I think if you've been trying for 3 to 6 months and you're not being successful, you should seek out help. At the very least, call your primary care doctor or go see a fertility specialist, but don't wait, because invariably I see some people who may wait too long, especially my couples who are closer to 40 and above. So that's not necessarily a good thing. And now the American Society of Reproductive Medicine is even recommending for women around 40-ish, you probably want to be more aggressive with those couples and get them to treatment as fast as you can. If you have irregular cycles, does that mean you are infertile? Not necessarily, because you don't know why your cycles are irregular. Is it because of early pregnancy, right? Common things happen commonly. So sometimes people will spot in pregnancy. Is it because you have polyps in your uterus that's making you bleed at abnormal intervals, or even fibroids? So if the menstrual cycles are not cyclic and you track it with a menstrual app, there's so many of them out there now that are very good, and you're getting some irregularity, you need to have a workup done to figure out why. Don't just say, oh yeah, it's always been that way. Oh yeah, that's the way it is in our family. Find out why, because there may be an underlying serious problem. Another misconception is, yeah, infertility is an old people's issue. It never happens in young people. Not necessarily. So we always ask for men, for instance, have you had any trauma around your pelvic region? Some people might say, well, gee, I had mumps when I was a child. Or I had a case where a man was said he had an accident where his pelvic bone was crushed as a teenager. Or young women also suffer endometriosis and fibroids. So that is actually not true. So if you can't get pregnant, it doesn't matter what age, please, please, please seek help. Does stress cause infertility? That's another question that people ask. It's probably the other way around. The lack of fertility induces stress, right? So by relieving the stress, you may help treatment, but stress by itself does not lead to infertility. It's the other way around. Does food affect fertility? Not really. I think we go for having a general balanced diet with good vegetables and berries. So food does not cause infertility. We usually tell patients to strive for a healthy mix of food that would help them. Infertility can always be cured. Not really. Sometimes you just can't treat it. Sometimes you can't cure it. And that's just the way it is. Your overall health does not impact your fertility. That's not true. So your overall health, if you have diabetes, if you have the renal problems, if you have general diseases or general overall poor health, that could affect your ability to get pregnant. See. Okay, oh, I'm sorry. Yeah, there we go. Now, all fertility treatments are expensive. Not so. I actually wrote a blog, so you can go to my website and also go to my LinkedIn site, where I reviewed several articles where they looked at a combination of having the ovulation app plus a combination of you can look at a combination of fertility markers, for instance. So that would be things like, let me rephrase that, I'm sorry. So things like your app, for fertility app, if you combine that with things like fertility markers, for instance, the incidence of success goes up. So you can have interventions that are not expensive at all, and you can get success with that. If you have a successful pregnancy, does that guarantee that you will have future successes? Not really. So you might successfully get pregnant, but not be able to get pregnant with a subsequent pregnancy. So that has to be looked at. If someone is not successfully getting pregnant after having a previous pregnancy, there may be new things that have risen up that needs to be dealt with. So that is some of the facts that I sort of handpicked, and I want to open the floor up for questions.
Thank you so much. I was actually laughing at some of those myths that you put up there, that you came up with. Thank you. But I wanted to ask, for some more explanations on some of the, technical words like aneuploidy. You were
Yes.
talking about men too need to be cognizant of the fact that the sperm gets old. So
Yes.
the older they get before they get married or start planning having children, they could also have problems with fertility, or
Yes.
have problems with having a healthy child. So what is aneuploidy, just for our audience?
I apologize for that. I
No.
think I've done some series in the past where I talked about it. So basically, when you fertilize an egg, the DNA of the egg must align with the DNA of the male. Okay, it's because the DNA of the egg contains only half the genetic material. It's been reduced to produce that egg. The DNA of the sperm has the other half, and it's the combination of the two. It's the combination, I'm sorry. It's the combination of the two that now combines to create a separate individual with 40, the full complement, which is 46. You'll see the word 46N, right? And you might hear the word 23. So an egg is 23 chromosomes, sperm's 23, combine, you get 46. Now, what happens most of the time, and this is why you see a decline with women, imagine being frozen in the state of musical chairs, right? Where you're half in and half out of the chair. What happens is the DNA of the egg is aligned along the center of the nucleus, and it is tethered to the ends by microtubules, right? And those microtubules are held down by a core called a kinetochore. Since division is suspended in the egg from birth on, right, and it resumes upon fertilization, those microtubules start to break down. The energy required to hold it is just not there. And you might hear a lot of research being done about the mitochondria. That's the powerhouse. That's the nuclear power plant of a cell. And you start to see aberrations in the mitochondria in an egg. So when a sperm comes along, the alignment of the egg with the sperm may not be perfect, right? Some is dropped, some extra going on, and you get what we called a state that is not euploid. Euploid being the combination of the two, making 46. Anything other than 46 is now called aneuploid, not euploid. Now, so that you see that trend with increasing age of the egg. But you can also see it with increasing age of the sperm, because what happens is you get what is called oxidative stress that damages the DNA, and you have increased, it's called DNA fragmentation, where your DNA starts falling apart. Now, the human body is phenomenal because there are machinery in place to fix these damages. But as you get older, it's harder to fix those damages. And by the way, that's how you age, right? Your body just doesn't repair the DNA damages as well. There's now data in mice where they actually forced the repair of this DNA damage and were able to make the mice appear younger. It's not ready for prime time because when they mated those mice, they had so much genetic mismatch and all kinds of problems that it's probably not sustainable. But if you're scientifically inclined, it came out in Science magazine. I think it came out from Harvard a couple of months ago. You probably have heard about it, but it's not ready for prime time. And so the subsequent damage to DNA plays havoc with the ability to combine properly. And you have an embryo a resulting embryo that has chromosomal problems. Those embryos, when they do implant, right, in a uterus, can either A, not even implant at all, so you'll never get pregnant. B, implant, fall out, get a miscarriage. Implant, you have a birth defect, right? So majority will not survive. Very, very few do. And the few that do, you might see out there, is Down syndrome, which is trisomy 21. But the vast majority of Down syndrome embryos actually don't make it. 80% don't. So it's very hard to have a successful live birth when you have DNA damage. I hope that answers that question.
It does. Thank you. So there are problems if these things are not done on time.
Correct.
Please, my 2 cents, my admonition is that young people on the forum, bring us your wives and your husband. I say it all the time. Let's do this quick. We'll work out the rough edges and all, after that. So please get married, start procreating. Otherwise, we have Dr. Famuyiwa. There'll be
freeze your eggs and freeze your sperm. Yes, Dr. Ajagbe.
Yes, Dr. Ajagbe, please. The floor is yours, sir.
You're muted.
I said you are muted and I'm muted. Isn't that interesting?
Thank you for the presentation. I know there are so many, the list is inexhaustible, actually, if you're going to think about all the myths and misconceptions and misinformation about pregnancy. Because everybody's looking for a scapegoat. Who should be blamed?
Correct.
But you mentioned something about food not affecting it. I know definitely there are some foods that increase the production of prolactin. Prolactin seems to be inhibitory in women, in getting pregnant. Could you say something about that?
So prolactin in high amounts can make your cycles irregular. However, the most common form of elevated prolactin comes from a benign pituitary adenoma. And usually we discover it when people are trying to get pregnant and I check their prolactin level and it's mildly elevated, and then I say, well, let's repeat it again. And it comes back even higher. Then we go looking. So you might discover that. Also, prolactin goes up in pregnancy because you have placental prolactin, right? That might affect it. So when I say food does not affect fertility, what I'm referring to is that it is recommended to have a broad variety of healthy food, right? So if you invest in junk, right? Junk in, junk out. So don't be surprised if you have junk out. Oh, by the way, this is really curious. I think it was about last week in Canada, they now released a statement saying that the Canada Department of Health or whatever agency is now saying adults should avoid going over 2 alcoholic beverages in a week. You know, it's not a vitamin. It doesn't do any good for your sperm or your eggs. So there's a direct correlate with abnormal sperm when you have increased alcohol intake, right? And also smoking, if we're going to throw things in there. So that's what I was referring to when I say that.
Okay, thank you.
You're welcome.
Thank you. That's an interesting finding that I think more research needs to be done on, because we know the cardiovascular effects on of alcohol.
Correct.
On cholesterol,
Yes.
the good cholesterol and the bad cholesterol. We do know that. And we do know, by research, how much alcohol a man is to drink, no more than 2 glasses a day, and a woman no more than 1 a day, to get those benefits of increasing the high cholesterol, decreasing the low one. So if now research is showing that alcohol, you said more than 2 glasses a week?
That's what they actually made it. You can look it up. That's the new recommendation that they came out.
Yeah, it's great. No, I'm excited about it, but more research needs to be done.
Correct.
To affirm that. That's an interesting finding. I would love to see more on that. Fantastic.
Yes.
Thank you. Thank you, sir, Dr. Jagbe. Sister Attorney Tinu Akinshola, our own very attorney in the house. We have so many fantastic attorneys in the house. Oh God, please don't let me get into trouble. Because I don't want to seek you guys for that.
I know. Thank you for calling me. Thank you so much, Dr. Famuyiwa, for always doing us the great job. So I have the question I had before Dr. O finished her statement is that we're talking about fertility, then the low sperm count and
Correct.
stuff. So I want you to help me. At what stage do you think that we should also be testing men's sperm count when the couple, comes in to consult with you? Because usually, as
Gotcha.
Africans, all eyes are like, oh,
I got you. I understand. Yes.
So,
yes.
okay. So that's one.
I'm glad you brought that up. Excellent.
Oh, okay. The other, thank you. The other one that came up now is with the alcohol thing.
Right.
I don't drink at all. So what happens to people like us who don't drink if they recommend 1 glass, for women?
Well, look, you don't have to, right?
Okay.
There are so many other antioxidants out there, right? So why consume it in the form of alcohol? I particularly love berries, right?
Yes.
I'll eat raspberries. They're very, very rich in antioxidants. I'll eat kiwi, very rich in vitamin C and antioxidants. Pineapple, the core of the pineapple, very, very rich in antioxidants. So there are many other ways to get it. Doesn't have to be alcohol.
Exactly. Okay, right. Thank you.
So, anyway,
it makes sense now that you said antioxidant. Maybe I missed that part. So, okay.
Well, I like to get I like to eat my antioxidant. So, and I use a combination of nuts. Right?
Yes.
Dr. Jagbe was just making us all salivate here, chewing nuts in front of us. So your nuts, almonds, very rich. Now be careful with nuts because they're calorie dense. So be careful, you could gain weight, just a little bit of it. But you could eat all the raspberry you want, the blueberries you want. If you're going to do strawberry, make sure it's organic because the pits makes it conducive to assimilating pesticides. So, but you have your kiwis. Do people know how delicious kiwis are? I mean, I cut that thing in half and squish it into my mouth, and it's wonderful. and it's a good snack, right? Your oranges. I mean, we all
Yes.
eat oranges, so there's
Mhm.
so many things you could be eating if you want to snack, right? That will give you the same benefit. So I would lean towards that. But to go back to your first question, right? At what time do you test the man? Well, in my clinic, I always tell my patients, we work as a team. So there's no such thing as, oh, we're going to test the woman first and then we're going to test the man first. I mean, a lot of times I have gentlemen who actually drag their wives in, or they'll come in first actually. So it's a team effort, and I tell them that. So while we're working up your wife, we need to be working up the man as well, right? Because otherwise, all you're doing is delaying therapy, right?
Yes.
It takes a while to get some of these workup done. So you do it concurrently,
Okay.
right? So while the woman is getting her stuff done, the man's getting his stuff done. And actually, some of my referring doctors, I just send them a list of tests that I think I want them to complete for me. So a lot of times, by the time the couple come to see me, I have a lot of these preliminary tests in front of me, and I love it because then we can actually dive down to, okay, let's talk therapy, let's talk treatment. So if you don't work the man up at the same time, all you are doing is delaying treatment.
Makes sense. Thank you.
You're welcome.
Thank you. And just to buttress that, I am not encouraging alcohol drinking at all. I'm saying what research has shown, if you don't drink alcohol, you really don't need to drink it. Actually, that's a better place to be. And you know better than anybody what to eat and what not to eat. I can put you on this forum and you will do an excellent job, advising us what to eat. So stick with those.
Actually, I was about to cut open my pineapple. So
there you go.
I just finished my berries, but
very rich in eat the core. Love it. Love it.
So it's the antioxidant word that was missing in my perception. Yes, thank you.
Yeah.
Thank you. So that's fantastic. Thank you. Health Matters taught us all of that. And thank you for that nuts thing. I'm eating a lot of it.
Yeah.
I learned that in Health Matters. So Dr. Ezugu, go ahead, sir.
Sure. Again, thanks again for a wonderful presentation.
Thank you.
Just wanted to make a comment on the antioxidant that you're just talking, especially when it comes to alcohol and the heart. People tend to drink it.
And by the way, Dr. Ezugu, sir, people who don't know, Dr. Ezugu is a cardiologist. So I know when I said heart, he's going to get me. Go ahead.
Yeah, of course, again, red wine, boasts of antioxidants in it, which is true. But remember, these are really, if they are fresh and you grow the vine and you just get it from there and you drink it. When you begin to age them, which is really what happens, they age them, cock them down several years old, the antioxidant level just goes down very quickly on these things and becomes more of a problem with blood pressure issues and other cardiomyopathic problems than really the benefits that you really want to get from it. So I would encourage you, if you are doing it that way, have a vine, just like your garden. And then you bring it out and then you drink and eat dinner with it. That's best benefit. Okay.
So when you say have your vine, what do you mean? Your fruit?
No, when you grow the grapes in your vine, like a vine, and you get the grapes, and then you squeeze the wine out, like you have
freshly.
Your own, freshly, that's when the antioxidant is best. Once you age it and cook it and preserve it, then it becomes really more of an bad alcohol. Really, with an antioxidant will go down as the age goes. Yes.
Yeah. So in case you want to look it up, it's Health Canada. They released their new guidelines, and it was actually like 5 days ago. Canadian health officials overhauled their guidelines, stating that they recommend no more than 2 alcoholic drinks per week.
That's awesome.
Which is a dramatic reduction in what their previous recommendation was.
That's awesome. Some of us always wonder why so much alcohol recommended per day when we know that the effects of alcohol is so bad.
Right.
But hey,
I
good
think
for you.
that if you look at the wine valleys in France, they actually love Nigerians. I think we've contributed significantly to their GDP at the cost of all their liver disease, I might add.
Yeah, yeah. Could you comment on the cost? I know you had mentioned that before of
Right.
freezing eggs and all
Correct.
this, because I do know that some people really comment that the cost is too much, and some in England is cheaper or free or something. Can you just
Well,
comment on this costing on this?
correct. Ultimately, the trend in fertility is going to become regional, right? So yeah, you could say, okay, fine, it may be cheaper in England, but then you take time off work. What is the cost of your lost income while you're away, right? And then you have to go there, you're going to incur hotel bills, travel bills. So when they look at those low prices, they have to add those up to decide. We charge $69.50, which is a very moderate price. And we're trying to advocate for the cost of medication, which keeps going up every year. But you'll look around most places, some places charge upwards of $10,000 to freeze it. It's $6,950 at our clinic. And for freezing sperm is like $450.
Thank you.
For $450 per month,
Correct.
a year?
No. The initial freeze. To store it is like $25 a month.
Oh, you said $450 to freeze initially,
Correct.
and then $25 per month.
25 to 50 a month, yeah.
And what
So-
about the egg? What about eggs?
$50 a month to store it. But we try not to keep long-term storage in our facility, only because I don't want to hold on to anyone's eggs or sperm for the next 10 years. So we usually have them sent off to long-term storage facilities.
And so in the long-term facilities, that's $50 a month. How much is that?
Long-term storage facilities probably cheaper than what I would charge because they do it by the thousands.
Okay.
And but the initial freeze for females is $69.50.
Correct.
Okay. that's
Correct.
it. Okay. Thank you.
Yes.
That's good
So
information.
you talked about overall.
Quick question. That's $69.50. That's $69.50 or $6,000. You guys kept saying $69.50. Just want to make sure.
Very cute. That prices actually might go up. So
It's $6,950. She said some places charge $10,000.
Okay, thanks for the clarification.
Sure?
Yeah.
I love that. Yeah, if the sperm is $450, that could be $69.
That's
I
right.
know. Why is the sperm so much cheaper? That's craziness.
Mhm.
Because I don't have to give them medications and do ultrasound and monitor them for almost 10 days to see if the sperm is adequate enough to freeze. And I don't have to pay anesthesia to sedate them to collect the sperm. I don't have to buy any intravenous medications to sedate
Okay.
them. Those medications are expensive. I don't need an ICU nurse or an ACLS certified nurse to recover them.
Huh.
Wow, the things that women go through. Whew.
I know, right? We need to talk about that because men
Yeah.
need to have more respect.
Not fair.
We do have respect for you guys.
Thank you.
He said not fair. Whew.
Thank you. I know. You know what? Let me just, raise my hat to the men on this forum, on this platform, all respectable men. You all are. You are respectable because you do respect us. You protect us. You guard us in every way possible. So I say thank you. Just on the side, thank you.
Thank you.
So, you did say, I have a question. You said overall health does impact fertility. And you mentioned diabetes, you mentioned kidney disease. I'm just wondering what part weight may have in terms of overall health and fertility.
I mean, I think that you're probably referencing obesity. So if obesity, you have abnormal, you have increased increased infertility when in patients who are obese, and also it's very difficult to treat patients who are overweight. So you have more risk, you have more complications in patients who are overweight. And most fertility clinics will probably tell you, and I've started being more strict with that, that if you want to go through treatment, I probably advise you to lose the weight first before we go ahead, because there are complications that can happen.
So complications, but what about getting pregnant? How easy is it? Because I see women who, before I refer them out to you, to fertility clinics, who have hyperglycemia, by their A1C, meaning that their blood sugars are high. They're not diabetic yet, but they're trending towards it. And they have weight on them. And they have this infertility issue. Sometimes I actually start them on medication like metformin before I refer them out for fertility treatments. So how about, my question really is, how does it impact them getting pregnant? The complications in pregnancies there
A
too.
lot of times it could be an ovulation, right? Because if they have excess weight, then they have increased estradiol being released from the adipose tissue. So you start to get irregular cycles and they don't ovulate
So they don't
consistently.
ovulate. Okay.
So that presents a problem getting them pregnant, right? And also the risk of other concomitant diseases. So the elevated body fat with increased estradiol level increases the risk of endometrial cancer. So I have some patients now that I tell them, until you're cleared of the endometrial hyperplasia, we can't go forward. And sometimes they can't clear it, right? Because if it's atypical hyperplasia with also all sorts of abnormal cells, the GYN oncologist may say, gee, this is a patient that I actually may want to remove the uterus to prevent it from progressing to cancer. So what they might sometimes do is leave a progesterone IUD in place for a while to hopefully have the progesterone counteract the hyperplastic effects, right? So we can't start them. And then there's another one that we did start. I couldn't get her to ovulate with milder medications like your letrozole, which is an oral pill. And in such patients, sometimes you give the letrozole over a prolonged period of time. That seems to work in my hands. There's now literature to support it. You could also add the injectables. Now, the problem with the injectables is if they hyperstimulate, they are so at risk for being so sick that you probably just cancel the whole thing. In fact, there was a lady that, and also when I collect eggs, when we do egg retrievals, patients are sedated, right? They're under anesthesia, much like your sedation dentistry. Anesthesia tells me, well, we're not going to do it. Yeah. Well, and then I tell them, if anesthesia comes in and cancels the case done. He's not going to do it if you're not under a certain BMI. It's his license, so I'm not going to force him, because they have to breathe on their own, right? And imagine you have to intubate someone like that on an emergent basis, or if they aspirate, right, and then you have to put a tube down and they're gurgling. It's very difficult. And we're in an outpatient setting. I'm not at a hospital where I have ENT, I have anesthesia, I have a crash team, I have a code team at my beck and call. This is outpatient setting. So we're not going to give you enough sedation where you cannot breathe on your own. You have to breathe on your own. And I tell my patients, we're not going to do the work for you, right? So you have to be in enough shape for all that to transpire in an outpatient setting without me having to put you under general anesthesia and intubate you, right? That's a no-no.
Wow. All because of weight. So
Correct.
Even in fertility, then obesity is a disease entity, like we now know it.
Correct.
In the past, when I first finished medical school, obesity was not a disease entity. but now it is. So it's very interesting that most of the things we discuss, we come back to this place where lifestyle changes
Correct.
just so important.
Yeah.
Absolutely.
What we eat, we need to control that weight
Yeah.
and just stay healthy.
Yes.
Dr. Izugu, if Dr. Izugu unmutes, he would agree. If our, Dr. I'm looking at the doctors on the platform, any other doctors on the platform, all of them would agree. Dr. Buka is on there, she would agree. She's an anesthesiologist. She definitely will not even intubate the person in the hospital and say, forget it. So we need to be mindful of lifestyle changes, no matter what age we are, to maintain appropriate weight. So,
Dr. Famuyiwa.
Yes, sir.
So for those who have sleep problems and they're constantly on caffeine.
Oh dear.
They're constantly drinking something to stay awake during the day, and they still don't sleep well at night. The vicious cycle continues. How does that play in the this whole arena of fertility?
Well, I don't have that many patients, but most of the patients that you're describing also tend to have weight issues, right? Which will fall under the category of them being evaluated by the anesthesiologist prior to. And I always tell patients, it doesn't matter how much money you've spent, right, on medication, on the stimulation, on paying. On the day of retrieval, if you are deemed unhealthy enough, anesthesia has the right, they have the medical right, the medical authority to cancel your procedure. So don't be shocked if you show up. And after I've said, I don't even let such patients get that far. I'll have anesthesia come in and pre-op them and say, well, what do you think? And we'll make recommendations. Go see your internist, go get this evaluated. And at the end of the day, keep in mind that you are not suffering a life-threatening problem, right? It's not like if I don't do a stimulation, it's going to lead to death. But my doing a stimulation and treating you in a very unhealthy state can result in mortality, right? So we have to keep that in mind, right? You're starting with a healthy human being. Well, not healthy, but someone who's not critical. And you're going to do something elective to them. And now you move them to the realm of critical where they need to be in the ICU. I think not, right? So, so if they're not healthy enough, we're not going to do it.
Yep.
Thank you, Dr. Famuyiwa. I agree with everything.
Thank you.
And that's our anesthesiologist.
You're not likely to get too much sleep apnea from them. They're usually younger. So you're not likely to get a lot of the issues. But there's a little bit of hypertension you can work through depending on the circumstances. But on the average, they should be healthy for such an elective case.
Yeah.
Well, I don't know. I saw a 38-year-old recently. I don't want to say what day, but it's within the last couple of days, who has sleep apnea. Huge. BMI, that's the body mass index. That's what compares your height to your weight, was over 50. It was about 50, 56, 57, and it should be 19 to 24.
Dr. O,
Yes,
that person wouldn't even start treatment with
okay.
me. We wouldn't even get that far.
You can't put your legs up on the stirrups either.
We can. My table has a critical mass where it won't extend. We just won't do it. I tell you what, many moons ago, I had a patient who had a high BMI. I can't remember which one. And this was in the day where hyperstimulation has really almost been a thing of the past because we're now exceedingly careful. If someone's going to hyperstimulate, I can always cancel and say, we're not doing it. But this lady hyperstimulated and she got ascites and pleural effusion. And when she went to the hospital, they could the needle couldn't even get to her pleural space. That's how big she was. So I'm like, no. And then she made it through the ICU. She was discharged a couple of weeks later, recovered and everything. Showed up on my doorstep a month later and ready to start. I'm like, oh no, you're not. We're not. You dodged a bullet. We're not doing it. We're not going to do it. You can always adopt or you can lose the weight. But we're not going to do it.
So kindly explain what hyperstimulation is.
Oh, so when you stimulate the ovaries, normally I tell patients, your body, your brain does that
So
for you.
why do you stimulate the ovaries? What does it mean
Right.
to stimulate the
So
ovaries?
I was kind of in my usual fashion,
Don't
getting
worry.
there in the
I'll
prolonged
bring you
movement.
back. I'll bring you back.
So normally the brain stimulates, or the way I like to say it is, you have a fixed number of eggs, and those eggs are constantly growing to about 8 or 9 millimeters and dying off, right? So you have the progressive death of the eggs. And at that
So,
phase of
Dr.
growth,
Famuyiwa,
it's called.
Dr. Famuyiwa, just a minute. In case somebody does not know, every woman is born day one with a certain amount of
Correct.
eggs. They don't grow more, they don't get more.
Correct.
That's the eggs they would have till they die. So
the eggs are numbered. Eggs
Yeah.
are so numbered. Okay. So, but you continue to lose them in this cycle of programmed cell death, right? It's an ongoing process. Now, when they manage to get to about 8 or 9, 10 millimeters on their own, in what is called a gonadotropin independent, meaning independent of the brain growth, if the brain happens to be ready at that time and sends the requisite amount of follicle stimulating hormone, you can actually recruit a basket of these eggs that are going to be that are going to die, right? And then those eggs that are selected by the brain actually chooses one as the dominant follicle, and it tosses out the basket, if you will. So when we stimulate you, say for IVF, we're trying to rescue that basket that's going to be tossed off anyway. It's the same thing you do when you're donating eggs or you're freezing your eggs. Okay. Now, I'm going to stimulate the follicle that houses the egg to get big. And as it gets big, the supporting cells around the egg produce estradiol. They nurture the egg, they make it mature, ready for fertilization. Okay. And normally the brain does it, and it only does one egg at a time that gets there. But imagine me now sort of kicking the brain out of the way, which is what we do. And then instead of selecting one, I want to stimulate that whole basket, is what we want to do. You might average about 12 to 15 follicles that mature in a stimulation. But if you happen to have a lot of underlying eggs, we call it your intrafollicle count, maybe you stimulate up to 45, 50. That's a lot. So what happens is the egg surface is stretched, right? And the ascites you see and that's called hyperstimulation, with hyperstimulation, is not because of liver failure initially. It's because when you stretch the ovarian capsule, you now leak protein as a transudate. The protein leaks out, gets into the abdominal cavity. And that protein, it creates an osmotic gradient that now sucks fluid from everything else, your blood vessels, your viscera, your bowels. So that fluid now accumulates, trying to dilute down the protein, right? And it's not because of liver failure, which is portal hypertension. The way you treat the two are very different. And sometimes I'll get an emergency room doctor panic. Oh, why did you do that? Well, with ovarian hyperstimulation, it's a transudate caused ascites. You want to reverse the concentration gradient back into the blood vessels. So you give a high salt content to hopefully pull the fluid back the other way and help resolve and reduce the ascites. And also, when the ovary surface is stretched, there's something called VEGF, vascular endothelial growth factor, that is also released in high amounts. And this makes the ovary more porous, right? So the patient gets sicker. So one of the medications we use off-label is cabergoline or Dostinex, which is normally used to treat prolactin. It can reduce VEGF and helps to terminate this hyperstimulation syndrome going on. Now, hyperstimulation resulting from excessive stimulation from the follicle, or maybe excessive response to the gonadotropins, because not every woman hyperstimulates. It's made worse when a patient gets pregnant. Why is that? Because your gonadotropins, the factors that are coming from the brain to the ovary, are made up of an alpha and a beta subunit, right? It's the same. So there are several proteins that affect different organs in the body. For instance, TSH from the brain affects your thyroid. CRH goes to the adrenals. FSH likewise goes to the ovary. The thing about them is they all have the same alpha subunit, different betas, but the same alpha. So when you get pregnant and your placenta starts making HCG, which is a similar type of protein, you're making it with a different beta, but the same alpha. Now, if you have excessive levels of alpha, it doesn't matter. It won't recognize which one goes to liver, thyroid or adrenal or ovary. That alpha, the excessive alpha in the HCG, will continue to stimulate their ovary as if you were still giving them medication. So then you have a prolonged late phase of hyperstimulation. And people really do get sick, right? So if I have them in the hospital, which I haven't done in over 20 years, you have to give them albumin, again, to sort of dilute the protein concentration in their ascites and help reverse it. You keep them on Dostinex to help reverse and terminate the process. But it can drag out if they get pregnant, right? So you really want to avoid it. And I think probably most people in America successfully avoid such a complication nowadays. We just know too much with the physiology of it that we definitely try to avoid it.
Thank you so much. And, in a nutshell, stimulation is done to stimulate and collect those eggs, right?
Correct.
To collect them so you can freeze them.
Correct.
Or you can implant them right away, or
Fertilize
whatever
them.
you want to do, right? But when you have hyperstimulation, that's a complication.
Correct.
It means you've overdone it.
Correct.
Period. So I hope that question is answered. So if it's not, please let me know, and we'll tackle it again. So Haman from London said, how does the issue of lack of sleep due to prostate problems cause, I think he wants to write, affect sperm count and reproduction?
Well, I'm not a lack of sleep from prostate problems. That's
okay, the lack of
there.
sleep would be, a man has, large
Right.
prostate and
getting up to pee a lot.
Yes. So
Yeah.
they're not sleeping well because the getting up a lot to sleep is hindering their sleep. So
I would hope that such a person is being treated appropriately by a urologist. If I get male issues, I have a pair of fantastic urology doctors that are specialty trained just in the male fertility. So when I think anything is off course, I get them involved in the care right away, right? So my supposition is that it just probably affects their circadian rhythm, and that may affect the cyclicity of the gonadotropins, LH in this case, going to the testicles. But if I have men who have complications, I don't take care of it. I have wonderful doctors who are specialized in it that I partner with and they do a fantastic job.
So does this lack of sleep though affect sperm count?
I'm not sure that it does. I mean, a lack of sleep would probably indicate that there's something underlying, right? What would affect the sperm count is underlying ill health, right? So lack of general overall health will affect your sperm count.
But sperm count is not the only problem a man can have, or sperm count issue, meaning low sperm count. It's not the only problem they may have. They may have other problems, like the sperm is not moving the way it should.
So you're talking about a semen analysis, and there are several factors that you look in on the semen analysis to give you a complete analysis, such as motility, morphology, the pH, the volume, the how much fluid is coming out, how many white blood cells are in there, if there are red blood cells in there. In fact, some people have said the semen analysis is now your fifth vital sign, right? It's a vital sign. It's telling you that something is off. So if you see a semen analysis that's abnormal, right, it makes you go look at other things, right? It's something is off. Something is not. I tell you what, many moons ago, I had a gentleman who had I think it was one or two parameters were off, but they weren't that bad that some people would even overlook it. But I said to them, I said, it's not quite where I want it to be. So why don't we just have my urologist take a look at you, right? Nothing overtly bad. And so I sent him off. And lo and behold, I got a call and they actually found a tumor in his testicle, right? So everything was off, and it was a tumor that was starting to cause the abnormalities. And they were able to operate it in enough time that it did not become a problem. So when I see abnormal semen parameters, I usually am quick to get the male fertility urologist involved.
Thank you. That's my point exactly. And I would, explain again. I wanted to explain to Hammond that the only problem a man has is not a sperm count issue. There could be the sperm not moving well like it should. Some men they don't make sperm at all. We say they spermic. They don't make sperm. There are many issues that men can have. Like Dr. Famuyiwa said before, it is a misconception that infertility is a woman's problem.
Correct.
No, in some instances, the woman is perfectly fine. It is the man's problem. And sometimes it is both, like she alluded to in the beginning. So I just wanted to make that point to Hammond that there may be other issues when there is a problem. The man needs to be evaluated. So there's a question here that says, how does a new NP who is passionate about women's health get a fellowship or training in this area? Would you be open to take such an NP in? Because NPs really don't do fellowships. NP gets with, the specialists, like Dr. Izugu, cardiologist, like me, family practitioner, they come, they get trained, and they're in business. I mean, I'm not saying it's right or wrong, but that's the way it is. Do you take NPs to train them?
So I usually partner with some schools who might send their nurse practitioner students, and they do a rotation or two with us. But sometimes we are full and I can't accommodate it. And so if I am, then I tell them I'm sorry.
So everybody, go come out.
So she's actually talking about a full NP, somebody who is an NP already, but would like to do fertility. So this is not NP student.
All right, right. Unfortunately, I just hired one, and you can check back with me, maybe in about 6 to 8 months if we have openings. Um, and I think most nurse practitioners that go into fertility, basically, if I bring you on, you're going to be working side by side with me, right? The same way you teach a medical student, you have to learn it. And then I do assign readings, and I expect them to complete those readings. Um, and now the American Society of Reproductive Medicine, they have specific programs for nurses where you can actually complete to rapidly increase your knowledge in the field. But it's a very fascinating and fast changing field. So it demands a lot of reading and keeping up with things coming up. I mean, I'm constantly reading all the time. I download articles on my cell phone, and I listen to articles to work and listen to articles coming back home, and then I articulate articles and condense them on weekends. Is where I come up with some of my blog ideas. But it's a field where you have to be constantly reading. That's just the way it is. You have to attend conferences. There are conferences all over the world, several in the US. So I try to attend as many as I can, because you learn the cutting edge. You talk to your peers, you talk to the people at the cutting edge, and you keep learning. That's the key word. Keep learning.
Thank you. Auntie Susan say thanks you very much for the extensive explanations on fertility. And she asked, can a 75-year-old woman be a surrogate? What are the chances?
Okay, so
it's a very good question.
All right. I'm going to tell you what my professor from medical school told me a long, long, long time ago. I helped co-author a book called Contraceptive Technology by Dr. Robert Hatcher many, many moons ago at Emory. And Dr. Hatcher would tell you that a pregnancy state is a state of high risk. It's when you are pregnant, you have a lot of things going on with your physiology. So at 75, it's your whole constitution, it's probably not prime. So you wouldn't do that in America. Maybe you might do it in India or something like that. But the risk of death from surrogacy is real. So someone like that can actually die. It's probably something that you would not do.
Okay, does a 75-year-old woman even have the hormones still to support the pregnancy? Because there are certain hormones that, would go up before a woman gets pregnant, and then some goes down, some goes up during pregnancy. Does a 75-year-old woman still have those? I mean, in our time of today, Sarah did have a baby at 99, but, I'm just wondering.
I think that you have to look at the risk of mortality from pregnancy at that age is high, right? It's high. I mean, you've had some women who've had heart attacks or PEs at say age 55 or so. So now they actually discourage women from trying to use donor eggs to get pregnant at say at age over 52. Right? So their risk of complications is very high.
So I'm still wondering, do they have the hormones at 75 to support pregnancy? I understand the complications is there.
No, it's not that they have the hormone. You can give the hormones artificially. You have to give the estradiol.
That's another, I know.
If you give anyone with a uterus estrogen, you can prime the uterus enough to
I
make
know.
them sustain a pregnancy.
Oh, yeah,
Right.
it's happened. We had a senator's wife who wanted to become president. Remember, she did that. She was postmenopausal when she lost her son,
Right.
and she went back, got
Oh,
estrogen.
yeah. I have a
Just
lot
had
of
a baby.
postmenopausal
Yeah,
women too.
yeah.
But now they're starting to set an age limit,
Mhm.
right? I know in this area for sure, you get over 52, there will be no OB doctor who will take you on to deliver you. They won't touch you with a 12-foot pole. I don't care how much money you give them, because they don't want the complications. And I think that's a trend you're going to see, right? So someone has to put their pen on paper and say that if anything happens to you, they've got it. Pulmonary embolus, cardiac arrest, any complication of pregnancy, they've got it. Well, they don't want to do that, right? Because you could be in the ICU for so long. There was a Nigerian lady that died many, many moons ago who delivered, in her mid-50s. And now the child is left to be fended for by not the mother, by extended family. I remember one time I had a patient, when people try to play games on you, right? This is a Nigerian lady that in actuality was 62. And I told her, I need you to go get maternal fetal medicine clearance. So she goes there and goes to Nigeria and gets some document or the other that says she's 48 and goes to the doctor and he signs off on it. She comes back to my clinic. I go, I don't think so. And I called him up. I said, I don't think so. I don't care where you get this document from. This is not your real age. You could die. People don't realize they could die. Or somebody who in Chicago said, oh, yeah, I want to come see you. Like, why me? Between here and Chicago, do you know how many fertility doctors there are there? And she was trying to hide some medical facts from me. So when I asked for medical clearance, she went and got a Zoom doctor to write her a note saying that she's cleared. I'm like, well, then go back to your Zoom doctor and tell him to treat you himself. But I'm not touching you with a 12-foot pole. I'm just not.
But you also have to remember that at 75, we start looking at all the problems with geriatrics. So apart from pregnancy, we have all the other organs that
That's
are
right.
decaying. So
Yeah.
I don't see why anybody would risk their life for that.
And it is they do risk their lives. And there, I had this gentleman who kept telling me, oh no, we know for sure she's gonna be fine. Yeah, everything fine. I'm like, look, here's what I tell them. Do you know how many years it took me to get my license? How many years of training? I'm not interested. I don't care how much money you have.
So not a good idea for a
No.
75-year-old woman to be a surrogate. There are many young women who
Correct.
can do that. And they can do that here, anywhere. I've seen it done in Nigeria, and the babies are brought here.
Correct.
And they are American citizens because the DNA is from Americans.
Correct.
So 75-year-old, no. We want the 75-year-old to enjoy themselves, enjoy the remaining of their lives in bliss. So this has been a fabulous conversation. Well, I hope some of those myths, or maybe definitely all of the ones that you posted tonight, have been debunked. So to reach Dr. Famuyiwa, oh my gosh, I didn't post it. Well, contact me if you need to reach Dr. Famuyiwa by email, WhatsApp, directly, any which way, and you reach out. Also, you can just Google her online, and she's right there with all her information. Dr. Oluyemisi Famuyiwa, she does a fabulous job. I know many people who the Lord has blessed through her, who are now parents of healthy children. So thank you so very much for another wonderful Medical Mondays. Would you please give us some parting words, parting advice?
Well, fertility is my passion. I like to help people have children. It just gives me joy. But my definition, my job, my mission, my goal, my why is to help people have children. Now, whether or not you're having the children right now, or you're going to have the children in the future, But I think that people who desire parenthood should have the ability to be parents. And that's why I do what I do and what I love doing. So a lot of food for thought. I always tell people, think ahead. If you see childbearing in your future, whatever stage of life you're in, make moves. Think about it. Plan. You can freeze eggs or sperm now. It doesn't have to be right this second, but look into the future and say to yourself, do you want a family? As simple as that.
You want a family.
Mhm.
No, ní fún yàn
Fantastic.
ládírẹ́sì mo dẹ̀ ní contact wọn ní oníwà ṣùgbọ́n ká mi send sí nígbà kan rí tipẹ́tipẹ́ tó máa wà bẹ̀rẹ̀ ní mẹ́sẹ̀jì wa.
Hello, Mrs. Adebola. Contact wo lẹ ń wá? We're talking about Dr. Famuyiwa. Thank you for muting yourself. God bless you.
Thank you.
So be a blessing to someone by sharing the link, for Medical Mondays with Dr. Ho. And I want to make sure that I didn't miss any questions. I reposted the link. Somebody asked for that. Dr. Famuyiwa,
Yes.
comments on the platform, a lot of thank yous. This was an amazing session. Thank you so much to everyone for sharing their expertise. Sister Nicole said, insight and care. Thank you, Sister Nicole King. And my own big brother, Brother Yomi Lawal said, fantastic information, fantastically informative presentation. Kudos.
Thank you.
To us both.
Thank you.
Thank you, sir. And thank you for making a wider view of my health. That's Hammond from London. Thank yous all over. Great session. Thank you. Thank you so much, Satino Sister Umi. Thank you all. We appreciate you. Next week, gear up for that financial health. We all will be successful. Health-wise, we will be, financially, we will be. It's our destiny. Let's go for it. So we'll start this session. We'll restart. Why do I keep saying restart? We will continue the session next week. So until we meet then, please stay safe. Remember that, first of all, on this forum, we don't establish physician-patient interactions, but we can always link you to the experts as you need it. And remember that COVID is still very real. Flu is real. Monkeypox. There's one more thing, RSV, that makes people cough like crazy. So please be safe, stay safe, and we'll see you next week. Thank you.
Thank you. Thank you.
Thank you. Thank you very much.
Thank you.